Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Muy buenas, bienvenidos a esta sesión satélite de Hoya Surgical Optics que se titula Leading IOL Advancements for Presbyopia Correction. Vamos a continuar esta sesión en inglés, puesto que nuestros ponentes son internacionales. So we shall follow in English in order to be able to keep a good standard in the discussion. Let me introduce you to the speakers, Eric Mertens, Francisco Carones, and Hakan Kaimak, and I'm going to co-direct this session with Jorge Leo del Barrio, and we shall have at the end quite an important debate with, in which the participation of Ramon Ruiz Mesa and Roberto Fernández Guanaga will be very welcome. So first speaker is Eric Mertens from Belgium, and he will talk about this topic about the Vivinex geometric, which is a very innovative lens, a family of lenses that is successful in the practice of refractive lens HA cataract surgery. So Eric, you are the first to talk today. Thank you.
First of all, I would like to thank the organizers of ARI, Dr. Alio, for inviting me to present on Vivinex geometric family in a successful private practice. Hello, my name is Erik Mertens. I'm a vision correction surgeon based in Antwerp, Belgium. And this is my financial disclosure, which is relevant to this presentation. Now, when we look at the amount of premium channel IOLs being implanted in the world, we see an increase, gradual increase over the next years, and it will continue to grow the next decade at least. Now, actually, the penetration of these lenses is not so high worldwide. It's about 10%, depending on the region you are working in, but it's only 1 out of 10 patients which are offered a lens which gives, on top of distance vision, also intermediate and hopefully also some near or perfect near vision. Now, why is this adoption by our colleagues is that so low? There are different reasons. For instance, there's too much work. Implementing full range of focus IOLs into your practice means a lot of work by training your team, by increasing your share time with your patient, because you have to explain much more what is going to happen. The brain has to adapt to this new situation, which can take up to 6 months. So you have to explain much more than with standard monofocal IOLs. Some people think that these IOLs are still not good enough, or they are unfamiliar with the technology. The cost also plays a role, of course, because the patient has to pay more for this type of surgery, and also the surgeon needs to invest in his team and in pre-op diagnostic instruments to make sure that, like, the corneal surface is nice or good enough to implant these lenses. There's also confusion about the terminology. That's why it's best to talk about monofocal, increased range of focus, or full range of focus, to make it understandable not only for our colleagues but also for our patients. And already mentioned it, that we need sufficient pre-op measurements and precautions to deal with these patients and to implant these premium IOLs. Now, how can we exceed the expectations of these patients demanding a full range of vision IOL? That's where the Vivinex geometric trifocal IOL family comes into play. So they have the same add power for intermediate and for near, but they have a different distribution. As you can see here, there's different light distribution between distance and near. The geometric gives more light distribution to distance, and the geometric plus gives more to near. When we combine those lenses, as you can see in this graph, when you combine geometric with geometric, you lose some near vision. When you combine geometric plus with geometric plus, you lose some distance vision. That's why this study by Professor Kaimak from Düsseldorf is so important. By combining geometric plus and geometric, you get a very smooth transition from distance intermediate to near, and giving those patients a full range of focus experience.
So in most cases, when the eye is suitable, I go for a full range of focus IOL, which is most of the time a trifocal IOL. So the geometric family has the geometric and geometric plus, which gives the patients a continuous vision from distance, intermediate, and near. And so by pairing the geometric and the geometric plus with different light distributions, because they're both trifocals, this gives a very smooth transition from near, intermediate to far vision.
So how do I perform full range of focus IOL surgery? I do, in most cases, unless the patients do not want that, of course, bilateral sequential lens surgery, because we have then less visits for the patients in our clinics. And also the same images are projected into our brain, so the adaptation begins immediately and can start immediately for the brain to adapt to it. I perform femtosecond laser-assisted cataract surgery in those cases, and I perform it through a temporal 3-session astigmatism-neutral incision, because in these lenses you need to end up with astigmatism less than half a diopter to get optimal results. And for toric lenses from 1 diopter onwards of corneal astigmatism, I will implant toric IOL. I will show you a few case studies I performed in my practice, pairing the Vivinex Geometric and the Vivinex Geometric Plus. The first patient is a 56-year-old man who had LASIK in 2009, so many years ago, for a -2, and he wants to be spectacle independent after surgery. His best corrected distance visual acuity preoperatively was 0 logmar. First, we looked at the topographic map to see whether the laser ablation was nicely centered, which was in this case. And we also look for the pre-op higher order aberrations total. It has to be less than 0.3 microns to have a good result with those full range of focus IOLs when you implant them post corneal refractive surgery. So I did the surgery and I implanted a geometric plus in the right eye of 20 diopters and a geometric of 20.5 diopters in the left eye. The surgery was done in June 2023. 1 month after surgery, the uncorrected distance visual acuity was 0.1 logmar in the right eye and 0.05 in the left, with J3 for intermediate and J2 for near. The binocular distance corrected visual acuity was 0 logmar. The patient was very satisfied with the outcomes because patients who had LASIK in the past will, of course, be eager to become spectacle independent now. So that's what they drive. So that's very important. So he was spectacle independent at all distances, and he did not have problems with the halos and glare and reduction of contrast. As you can, is proven here by this higher order aberration map of the Osiris, showing there is not much of higher order aberrations left in these eyes. Patient 2 is 79 years old with anisometropia and astigmatism, and also wants to be spectacle independent. He had some cataract, as you could suppose, with a best corrected distance visual acuity of 0.2 logmar. I implanted a geometric toric in the right eye and a geometric plus toric in the left eye. 18.5 diopters in the right T4, 17.5 diopters T3 in the left eye. You can see here very nicely, these were the laser markings of the catalyst in the cornea, and here the markings on the toric geometric lens. So it's very important you align these two so you know that you correct the astigmatism in the right axis. 1 month after surgery, the patient had in uncorrected distance visual acuity in binocular of 0.05, intermediate uncorrected of J1, and near J2. Binocular distance corrected visual acuity was logMAR 0.0. So as you can imagine, this patient was very happy. So he had a better vision, clearer vision because of removal of the cataract. We got rid of the astigmatism and corrected intermediate and near as well. As you can see here very nicely, that the post-op refraction was very close to metropia. And also in this case, as you can see with the eye trace, this is a very nice example of a 47-year-old patient with hyperopia of about +4. Again, wanted to be spectacle independent. Those hyperopes, of course, are very good candidates for this kind of surgery. He had logMAR of pre-op of 0.0, best corrected distance visual acuity. I implanted a geometric 29.5 diopters in the right and a geometric plus of 29.5 in the left eye. This is me at the end of surgery, making sure that the lens is nicely centered on the visual axis, and the lights from my microscope guide me to do so. Also, removal of the viscoelastic in these cases in front of the lens and behind the lens is very important. Now, 1 month after surgery, uncorrected distance visual acuity was logMAR 0.05 for intermediate J1 and for near J2. The binocular distance corrected visual acuity was minus 0.1 logMAR. Here is the visual quality with the eye trace measured and close to 0 to get good results. So in conclusion, we can say that preparation is key. You have to also look at the corneal surface, whether it's good, and look at the retina, whether there are no puckers or other things going on. Do patient-friendly examinations. Choose the right high-performance IOL. In this case, geometric and geometric plus pairing is my preference. And under-promise and over-deliver in any kind of refractive surgery cases. I thank you very much for your kind attention.
Thank you very much, Eric. Has been an outstanding presentation. So we're going to continue with Dr. Francisco Carones. He's going to tell us about pairing energy transmittance to optimize results with full range of focus IOLs.
Hello. Today, I'm going to present on pairing energy transmittance to optimize results with full range of focus IOL. I have some financial disclosures to make, as you can read in this slide, and I really like to start from IOLs classifications because there are many ways for classifying IOLs. One of them may involve the optical performance. So we have static IOLs like monofocal, monofocal plus, bifocal, trifocals, etc. We have dynamic, accommodative IOLs, or we can consider the optical design where we have refractive IOLs, they change the curvature and bend light, diffractive IOLs with this surface incongruences, or pinhole IOLs, and more recently, ECOS Europe developed a classification based on the range of focus that the IOLs provide. So there are 4 different types of IOLs, monofocal ones, enhanced monofocal ones, able to give a functional intermediate, increased range of focus IOLs, able to provide patients with a functional near, and then full range of focus IOLs, really giving patients the widest extension of the focus and giving higher spectacle independence levels. Same can be said or showed with this graph. If we consider monofocal IOLs, we see that the extra range of focus is minimal or nothing. When we consider enhanced monofocal IOLs, the extra range of focus may give patients a very good intermediate vision. With increased range of focus IOLs, this increased range of focus can go down to a functional near. When we consider full range of focus IOLs, there is where the entire range is covered by these IOLs. What I'm going to present you tonight are results from the Hoya Vivinex geometric IOL. This is a static, meaning trifocal, diffractive, meaning with these diffractive incongruences that split light, full range of focus IOL, so giving patients the full range of vision without spectacles. Let me start talking to you about the light energy distribution through a trifocal IOL, because most, if not the commercially available trifocal IOLs, have this kind of energy distribution. They usually allocate more light for distance and less light for intermediate and near. This energy distribution can be very good under bright light conditions because there is enough energy for all distances and all the activities. But under dim light conditions, there may still be enough energy for distance, but the limited energy for intermediate and near may penalize some activities like reading at dark or reading at intermediate distance. So, the Vivinex geometric preloaded trifocal family involves two complementary designs based on some specific patent by Hoya Technologies. The Vivinex geometric is designed to provide a superior distance vision and still a well-balanced intermediate and near vision. On the other hand, the Vivinex Geometric Plus is designed to provide a superior near vision while still maintaining good distance and intermediate vision. So the pairing, or say the combination of these two different trifocal profiles may really provide patients more spectacle independence, more ability in performing in these conditions like dim light or when, trying to read in the dark, where the conventional profile of energy transmittance of the trifocals may be a little bit penalizing these patients. Here you see the defocus curve that you can obtain when combining these two lenses in the same patients is to have a very wide range of focus, but also a very high energy transmittance among the different distances at all light conditions. I'd like to present you my personal experience that involves now more than 100 eyes implanted, but I'm focusing on the 30 bilateral implants, meaning 15 patients, who received in the first eye implanted a Vivinex Geometric, and in the second eye implanted they received a Geometric Plus. And for all cases and all eyes, Plano was targeted as to give patients the best performances. Here is the defocus curve binocularly measured when approaching patients in the way that I explained. You see here how nice and wide is the defocus curve and how peaks at valley are minimized. So this combination of lenses really provide patients with a very significant length and distribution of the light all over the different distances. As regards to spectacle independence, when these patients are asked how often do you use spectacles or contact lenses, here you see a list of different activities performed under different light conditions and at different distances. And you see how high, how good is the profile of spectacle independence. Yes, there may still be situations like reading in the dark or maybe night driving where a spectacle may help, but the profile of spectacle independence that this approach is able to provide is really good. When patients are also asked how often they use spectacles, here you see that 88% of them never use spectacles. And this is a very nice profile. And it is also nice to mention that the 12% of patients who are wearing glasses, they just do it occasionally or sometimes. So no one uses glasses often or always. What about quality of vision? Well, as expected, this trifocal lens is going to give you some, night vision disturbances. But still, 64% of the patients have dysphotopsia either never or occasionally, and 12% of them have dysphotopsia always. So is this dysphotopsia bothering these patients? Here is the answer. when these patients are prompted with the question like, are halos and night vision problems really bothering you? You see here that 81% of these patients have either no or occasionally bothering dysphotopsia. So the profile of the night dysphotopsia of this combination is extremely good and extremely safe. So to conclude, diffractive optics can really perform differently, and not all trifocal IOLs are the same. The currently available trifocal IOLs allocate more light energy at distance to provide better distance visual acuity, but they penalize reading at the immediate and near when light conditions are dim. In theory, an IOL allocating more light energy at near may overcome this situation, but if this lens would be implanted in both eyes, this would penalize distance vision under dim light conditions. So the concept of pairing a Vivinex geometric allocating more light energy at distance with a Vivinex geometric plus allocating more light energy at near in the same patients really appears like a viable and elegant solution to combine energy distributions instead of focal distance. So it's a really nice solution for giving patients spectacular independence at all light conditions, dim light conditions included. Thank you.
Thank you very much, Francesca. Now the next speaker is Hakan Kaymak from Germany. He will talk about pairing trifocal IOLs with complementary light distribution, rotational multicenter clinical trial. You are the next, Hakan. Please follow.
Dear colleagues, thank you very much for the possibility to talk about our experience with a new trifocal IOL, and sorry for not to be on the boat with you. There is a new multifocal IOL platform, and there are two different kinds of multifocal lenses with different light distributions. So we have the same platform. We have a trifocal IOL with a near addition of 1.05 diopters and 3.5 diopters. But the difference between the two IOLs are the light distribution, which depends on the pupil size. So we have the geometric IOL or multifocal IOL, which is more far and intermediate pronouns, and we have the geometric plus, which is more for the near. We have also the possibility for the toric multifocal lenses, and all the lenses are preloaded. I would like to share with you the study results. The study was done across 10 centers in Europe. We had 3 arms, one arm with the bilateral geometric multifocal IOL implantation. The second arm was geometric and geometric plus as a combination. And we have the third arm with the bilateral implantation of the geometric plus. There was no test for distance and near dominance of the eyes, and the target for the residual postoperative refractive cylinder was 0.5 diopters. The intention was to minimize the need for spectacles, and we all know that the multifocal IOLs are very sensitive for astigmatism. These are my co-authors and also the principal investigators of the other study centers, which I want to thank. Interestingly, 2/3 of the eyes were implanted with toric multifocal IOLs. And this is really a huge number of toric multifocal IOLs, which makes it very interesting when we look for the study results. For the examination, I want to share with you just the visual acuity for distance, for different distance, also the focus curve, and what is very interesting, the questionnaire. The visual acuity was done under photopic and under mesopic conditions. You see here the visual outcome and also the postoperative refraction. It was really amazing. 84% of the eyes were within a spherical equivalent of -+0.5 diopters. The visual acuity for distance were very good in both lenses, so with the geometric and for the geometric plus. You see also that the intermediate visual acuity and the near visual acuity was increasing over time, I think, which is very important to talk with the patients before surgery for the expectations of the patients. So we had a very good distance-corrected monocular visual acuity with both lenses for distance. Corneal astigmatism is very important, and it's really mandatory in multifocal IOLs to correct them and to minimize them. You see here the results for the last visit. For the non-toric IOL, 96% were below 0.5 diopters. For the toric IOL with the 1 diopter on the IOL plane, 91% were below 0.5 diopters. And for the other toric IOLs, it was the amount of 83%. If you look for the toric IOL orientation for the stability, you see that nearly in 90% we were between 0 and 5 degrees. For a scientific view, you can see here again the distribution of the toric IOLs with the predicted and the residual cylinder and with the line for 0.5 diopters. Looking now for the binocular distance-corrected visual acuity under different lighting conditions, you can see here that we have a very, very good visual acuity for distance, also for the intermediate and for the near. And now for the binocular distance-corrected visual acuity, you see the difference between the combination of the geometric and from the geometric plus and for the implantation, for the bilateral implantation of the geometric. So looking for the winner of this contest, you see that for the distance, there is just a small difference between the bilateral geometric and the geometric and geometric plus. For the intermediate, we have a winner, it's the geometric bilateral implantation, and for the near, it's the combination of the geometric and for the geometric plus. And we see this again for the defocus curve. So that means that when we look for the intermediate vision, then we have a clear winner. It's the geometric bilateral implantation. And if we wish to have a better near visual acuity, then a combination of geometric and geometric plus, it's better. For achieving these results for the best corrected visual acuity, we have to optimize our constants for the multifocal IOL, and this was done nearly for 1,000 subjective refraction. So we have now an optimized constant which allows us to get ametropia. Implanting of multifocal IOLs, the most important thing is the patient's satisfaction. It's not contrast sensitivity, it's not visual acuity, it's really the patient's satisfaction. And this was looking for in the last visit. This is a questionnaire, and as you can see is that most of the patients, almost 100%, were really satisfied with the vision by the different vision distance. That means for distance, for intermediate, and for the near. And also, when we look for the satisfaction of the visual quality for day and night, you see that almost 100% of the patients were satisfied. And this is because I think we have a really, really good monocular uncorrected visual acuity. And this was, again, I can share with you the results achieved in 84% of the eyes were within a spherical equivalent of 0.5 diopters. I think this is mostly because we corrected the astigmatism, also the low astigmatism. And as you can see here for the toric and for the non-toric IOLs, or multifocal IOLs, we have a continuous visual acuity for the distance, for intermediate, and for the near. And you can see it for the monocular, and we have the summation effect from both eyes. We have a bilateral uncorrected visual acuity, which is really excellent for distance, for intermediate, and for near. What about the visual quality or visual disturbance, spectacle independence, which is the most important thing for the patient? This was also done with the questionnaire. You see here, we ask for glare, for halo, for starburst, and for blurred vision. And we look for the frequency, for the severity, and for barotham. And as you can see from the charts or from the points, it's very, very low. In multifocal IOLs, we know it's mandatory that all of them have halos because of the optical design. So you can't get a shower without getting wet. So this is normal, and the results and the points are very, very low. So the patients were really satisfied with their visual quality. If you look for the spectacle use, more than 90–95% never needed spectacles, and this is really for the different combination of the multifocal IOLs. So we achieved this in the non-toric and also in the toric group. If you look, so most of the time for everyday use, the patients were really satisfied. They don't need any glasses. So the conclusion of the patients, would you select the multifocal IOL again? And you see in 95% they say yes. Interestingly, one patient say no, but he recommended, I don't know why, probably for her stepmother. I don't know, but you see the satisfaction rate was very high. So the conclusion for the patients were really clear. They would select again the multifocal IOL. And what we conclude is really clear. We want to achieve emmetropia. So reducing the astigmatism to less than 0.5 diopters makes sense, and it's mandatory. We need this. So it really is important, and we have to think about to look for the astigmatism, also for the low astigmatism, to correct it. We have a really good orientation of the IOL. It's stable, so we can achieve emmetropia for the sphere and also for the astigmatism with this multifocal IOL. And then we have the best full range of focus for excellent vision, for this continuous vision. And we just have to select if the patient wants to look better without glasses in the intermediate or in the near zone. For the distance, I think it's the same if you do the combination. That's the reason why you don't need to look for a dominant or non-dominant eye. So you can choose the geometric bilateral if the patient wants to have a clear vision for distance and for intermediate, and he has also the possibility to read. And the patient is more a reader than the combination with the geometric and the geometric plus. I think it's the best option. Thank you very much for your attention.
Thank you very much. Excellent presentations. I want to invite all of you to enter into the commercial technical exhibition of ARI, and you will see the visual stand of Hoya, which is really very nice to look for more information about these lenses. Another debate will be led by Jorge del Barrio, so I think that we have very interesting topics to discuss. Jorge.
Well, first of all, thank you to all of you, and also thank you to Dr. Fernández-Buenaga that is here with us to share the discussion. I've enjoyed your lectures. Actually, I'm also a very happy user of the geometric. I really believe this is a very good lens, very good platform with a visual profile that now we're going to discuss. So my first question, I believe the study that was published by Dr. Kaimak is actually very important. So according to your personal experience and also what we have seen in your 3 lectures, so please tell me one by one, what are your, well, mainly, I'm not sure if, Roberto, you have experience with this lens, but basically, which is today, according to your experience, when do you consider the combination geometric plus, or the pairing approach, as we have seen? So, for example, starting with you, Eric.
Yes, okay, thank you. Thank you for having me. Thank you for that interesting question. When I started using the geometric platform, I was convinced that the geometric plus in both eyes would give me very good, the best near vision, that it's what most of my patients are asking for. But due to the study of Professor Kaimak, I started to pair these two, the geometric plus and the geometric. And I found that with the geometric in one eye, the distance vision was very good even one day post-op surgery, which was not the case when I implanted in both eyes the geometric plus. So nowadays, I never use geometric plus in both eyes anymore. My most cases are geometric in one eye and geometric plus in the other eye. As Professor Kaimak pointed out, I do not take into account the eye dominance. I place it in whatever eye patient, because the light distribution is the same profile, but the light distribution is different. So the brain doesn't capture the dominance and the more light distribution for near in the dominant eye doesn't bother them. So we don't care anymore about the eye dominance. And the geometric in both eyes, I only use them for people like accountants or people who are like 8 to 10 hours working on their computer screen. So no more geometric plus in both eyes. Most of the time geometric plus, and in a few cases geometric in both eyes.
And you, Francesco?
Well, Jorge, thank you for the question. I am echoing what Eric is saying. I started implanting geometric in both eyes just because when I started, the plus was not available yet. And so I have a series of patients who received the geometric in both eyes. Results are pretty good. I echo what was presented earlier. The advantage of regularly implanting a geometric in one eye and a geometric plus in the second eye, it is just in the simplification of the process without any real drawback. I mean, you will not find any systematic or significant compromise adopting this choice regularly, rather than really, selecting specific situations. So I'm ending up implanting only geometric in one eye and geometric plus in the other eye. And as Eric and Professor Kaimak already mentioned, there's really no need to assess the dominancy of the eye, which is still an issue, especially if you have cataract surgery. So one of the advantages of this strategy is a mix and match approach, which is not based on focal distances or technologies. The mix and match approach is a pairing approach, just based on the transmittance of the energy, either at distance or at near. That's the only difference between the two lenses. And this makes the selection very easy, in full honesty.
So, Prof. Kaimak, so in the end, I think we all agree that the dominance is probably not that relevant, but in the end, if you are going for the pairing approach, that is probably what we all are doing mostly, in the end you have to choose one eye for one lens. And so what do? Do you throw a coin, or you do randomly select by a software? Because in the end, for example, I know that doesn't matter, but since I'm measuring the dominance on the office at the pre-op, and I have to choose one eye, then I go with the geometric dominance, not because I think it's relevant, because basically I need to make a decision, and I think since I need to choose one eye, I do that. So in your experience, I know that the dominance doesn't matter, but then how do you select which eye is going to receive the geometric? Is it totally random, or what? What is your criteria in that regard?
Well, it's really random. I just start always with the right eye. When I'm doing the surgery, I'm also doing the simultaneous surgery. So it's really, it doesn't matter. I start with the right eye because it's the same procedure in the theater, and I prefer implanting the ViewNext geometric in the first eye in the right eye. So there's really no science behind it.
Yeah, you start is. And Roberto, you have a very broad experience with trifocal lenses. So do you have any question for the audience? And otherwise, my question is, what do you think about sequential or simultaneous cataract surgery for such trifocal lenses? Because these are actually today a big debate, no? And it's true that with the geometric, I'm a supporter of the simultaneous surgery, but it's true that those that support the sequential surgery, the geometric might offer the option of providing a lens that is going to give more, it's going to be more forgiving for far, and maybe making the patient less unsatisfied between one eye and the other. So what do you think, according to what you have heard and your experience?
Well, first of all, thank you for the invitation. I'm not a user yet. I will be, because I'm looking forward to implanting these lenses after these very interesting lectures. So, well, I think that it makes sense what we are saying right now. I mean, you can take advantage of having the information from the first eye to make the decision of the second, which makes sense. I would like to ask to the speakers whether they can share with us some pearls about the surgery, because currently most of the trifocal IOLs are reloaded, but some injectors are not that good. We need to enlarge the surgery. So I wonder if you could share with us some details about the surgery, which is the incision size. Do you need to enlarge the incision? How is the injection process?
Who wants to start?
Yes, please.
Me? Okay.
Please, Prof. Kaimak, that you raised your hand.
I'm doing really routinely 2.2 millimeters incision, and also the implantation is very, very easy with this system, this preloaded system, and that's the reason why I really love it. And I have really big respect for dry eyes. In those patients, I have to handle dry eyes. I think it's most of the really biggest problems that can happen. And the astigmatism below 0.5 diopters, then you win the game. You have to hit ametropia in one eye at least, and then you have a really satisfied patient. This is what my experience, to make it really easy.
Any further comment from Eric or Francesco?
Yes, I have to echo Professor Kayamak's discussion about dry eyes. When we measure the quality of the tear film and we see it's not good, like the non-invasive breakup time is even less than 8 seconds, I first treat corneal surface. I let the patient come back, and like in more than 25% of cases, we see a difference in lens power and difference in the axis of the astigmatism and even in the magnitude of the astigmatism. So even when you think you're doing a great job, when you do not take care of the corneal surface, you will mess up your result. That is very, very, very important. Secondly, the multi-cert injector, which is the preloaded injector delivered with the geometric. It's very easy for the scrub nurse to give it to the surgeon. It's delivered always in the same manner. So it is actually the first preloaded injector that I use that doesn't have flaws. And you also have a small, the tip of the injector can be minimized, so people who only want to have the tip in the incision and not having the tip into the anterior chamber can toggle that nose, so it's only going into the incision. So and also you have a screw or a push. So also to the preference of the surgeon, you can choose to push the IOL in the anterior chamber or in the back, or to screw. So you have many different options. That's why it's called multi-cert, of course, because you have multiple options for every surgeon's need or preference.
Any final remark, Francesco? Anything you want to add to what has been said?
I don't think there is a lot to add. I would just comment on the quality of the material. I mean, the geometric is part of the Vivinex family, and we are very, used to this material, meaning that it's glistening-free, very easy to fold, and very easy to release in the anterior chamber. So, in the capsular bag. So the haptics are very stable. So when correcting astigmatism, you will not see rotations in the postoperative period. So I think it's a very complete IOL from all perspectives. The geometry of the surface, the easiness for implanting, but also, as I said, the materials. It's a great material.
So thank you very much. I think it's time to close. So thank you to all the speakers, and also thank you to you, Roberto, for sharing this afternoon with us. So it has been a pleasure to be with you, and I hope to see you in the following meetings. Thank you.
Thank you.
Thank you.
Thank you.